This podcast is for general informational, educational purposes only and is not to be considered medical advice for any particular patient. Clinicians must rely on their own informed clinical judgments when making recommendations for their patients.
Welcome everybody to another episode of PHM from Pittsburgh. I am still your host, Dr. Tony Tarchichi. We are still coming to you from UPMC, Children's Hospital of Pittsburgh, and I am in the Paul C. Gaffney Division of Pediatric Hospital Medicine. For those of you who are new, we have been coming to you since 2016, kind of reviewing the American Board of Pediatric recommendations for pediatric hospital medicine, trying to walk our way through them. In the process, I've gotten sidetracked in a number of different ways, COVID, all kinds of stuff. And today we're here to have a nice conversation. We are going to welcome back, now we can say, friend of the podcast from our last episode, Dr. Jonathan Pelletier. If you did not listen to our last episode, I would recommend listening to that first. That's the albuterol in the PICU episode, because this is a continuation of that discussion. And what we're going to do today is just talk a little bit more using steroids specifically for bronchiolitis in the ICU. But as always, remember that if you want CME for this, free CME is available courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Without any further ado, let me introduce my guest and we'll get started. So Dr. Jonathan Pelletier is a pediatric intensivist and data scientist at Akron Children's Hospital, and an assistant professor of pediatrics at Northeast Ohio Medical University. He received his BS in microbiology from the University of Maine and his MD at Tufts University School of Medicine. He completed pediatric residency at Duke University Medical Center, and he completed pediatric critical care fellowship at UPMC Children's Hospital of Pittsburgh and a T32 postdoctoral fellowship through the Safari Center for Resuscitation Research. His research seeks to harmonize multi-center databases with granular EHR data to improve bedside clinical decision support, particularly as it pertains to respiratory failure. He's published several articles describing healthcare utilization for children with bronchiolitis and is especially interested in the impact of COVID-19 pandemic on respiratory pathogen transmission. So, John, thank you for joining us again.
Thanks for having me, Tony. It's good to be here.
Well, John, as usual, this is a CME podcast, so we have to go through our disclosure statements for any conflict of interest. I will go first and kick it out to you. I was a part of the Sanofi 2022 meningococcal vaccine immunocompromised advisory board. It should not interfere with what we are discussing today in the slightest. Other than that, I have no other disclosures. John, it's yours.
Great. I have no disclosures that should be relevant to this podcast. I have no external funding, but about 30% of my time is funded by Akron Children's Hospital as a data scientist and physician informaticist.
So now, John, we talked last time about albuterol and we talked about racemic epi, and we said we wanted to talk about steroid use. And just for background for everybody, if you're listening to the podcast, I don't know that you need the background, but to be thorough, this past, I'd say, year to 2 years, we have seen just a lot, but we've seen a lot of viruses that are not seasonal anymore. We've had more bronchiolitis than I can remember. RSV had a gigantic surge in the fall of this past year, more than I remember. I mean, if you remember the news articles about how many PICU beds were full across the country, adult intensivists were helping a lot of pediatric critical care units because there was simply not enough beds. But while that was happening, one of the things I was noticing as a hospitalist, some of my colleagues as well, is we were seeing more albuterol and steroid usage in bronchiolitis in older and younger people under 2 years of age than I had ever remembered seeing. And it just sparked the thought of why is it happening? So we made the last episode to kind of discuss with you and, representing all intensivists everywhere, exactly, what was the reason, what was going on, to have a really nice evidence-based discussion about it. And now we're going to continue that discussion along the lines of talking about steroids with bronchiolitis for these patients in the ICU specifically and on the floors. But John, that's kind of the background. Where should we go from here? Where do you want to start?
Cool. Well, let's dive into it. First by just setting up a framing for the discussion. So I think, when I evaluate evidence bases for clinical practice, I usually like to start broad and then go narrow. So the frame I would suggest for our discussion this time would be pretty similar to last time. I would say let's start with what the AAP has to say in their most recent iteration of the bronchiolitis guidelines. Follow that up by talking about the only Cochrane review that's been done on this topic, and then spend probably the last bit of the discussion looking at some of the nuances in the primary literature. Does that work for you?
Works for me.
Cool. Let's start broadly then, but not to bury the lead here. I think it's important to be upfront about the limitations on the data that we're going to discuss. So one, there is an important age caveat here. One of the things that was true, particularly in this past 2022-2023 RSV season, and one of the things we'll be discussing at Peds Academic Societies this year, is that there was a very substantial age difference in the patient population on average that we saw this year compared to in earlier years. Patients, depending on what definition you use, whether you're only willing to accept kids under 2 years old, if you use that age definition, then patients were on average about a month to a month and a half older than what we saw, which means in practice, a higher proportion of the kids we saw were toddlers, not babies. And thing number two is just to say, even though we can't really define them as having bronchiolitis based on our definitions, fully 15% of children who were admitted with RSV this year were actually between the ages of 2 and 5. So while we're going to focus on evidence-based guidelines that are really designed for infants, it's important to throw out the quick disclaimer that that doesn't necessarily represent the cohort of patients, at least that we saw in this most recent. Disclaimer number two is that the randomized control trial that I really want, the one I wish I had, I don't have. So I would love to tell you that I have after last week's discussion about albuterol and or racemic epinephrine in bronchiolitis, I would love to tell you that I have an RCT where they took patients, they evaluated their albuterol responsiveness, and then they only administered corticosteroids to children who were albuterol responsive, or in whom you might otherwise have biologic plausibility that they should respond. That trial doesn't exist, or at least if it does exist, I did a really bad job of finding it on PubMed, and somebody needs to troll it out in the newspaper or on a blog or something. So, with those important caveats, let's dive into the data that we do have. So, as always, I like to start with guideline statements. I think they're a fair place to start. Though, in some of the feedback we got from our last session, I do think it's important to point out, technically speaking, the AAP bronchiolitis guidelines have expired. Because they were written in 2014, the AAP guidelines automatically expire after 5 years. And so technically speaking, there are no current guidelines for the management of bronchiolitis according to the AAP. That being said,
can I interrupt you there for a second, John?
Yeah.
That surprised me when we were preparing for this. I'd forgotten that. I didn't expect that. So for those of you listening who were saying the guidelines expired, if you go to page E1474, it's in the legal disclaimer. And that's why I haven't read it, because there's a legal disclaimer on that page to the right of the actual verbiage in the guidelines separated from it. And to be frank, I don't, once I see the legal conversation, I stop reading, but that's where it is. And it clearly states that. That was a surprise. For those of you listening, if you're surprised as well, I encourage you to go check it out for yourself, but they are technically expired. Go ahead, John. Pardon me.
And I was going to say that was a surprise to me as well. I'm actually really thankful to the input that we got from the audience after the last session to bring it up, because I do think, well, maybe a nuanced or technical point, I do think it brings up that a lot of the literature in bronchiolitis has really changed in the last, almost 10 years now since the guidelines were published in 2014. In particular, we were using almost no high-flow nasal cannula back in 2014. And so it probably is a worthwhile just a quick pause and say it would be really worth updating these guidelines whenever, the AAP has the bandwidth and funding for it, which I respect can be limiting.
Sure.
That said, let's jump into what we do have. So to go back to the 2014 AAP guideline statement for the management of bronchiolitis, I want to start by being plain and clear. The exact verbiage from that is that clinicians should not administer systemic corticosteroids to infants with a diagnosis of bronchiolitis in any setting. They grade it as quality A evidence, and they make a strong recommendation for that. I am going to take a little bit of issue with the absence of nuance in that statement, and here's why. Let's look at the evidence that the AAP used to come up with that recommendation. And again, full disclosure, some of this evidence will now be outdated because the guideline was in 2014. So we'll talk about some newer trials as well that weren't included in that statement at the end. But so probably the strongest piece of evidence supporting the AAP's policy statement on that was that there was a Cochrane review performed in 2013 by Fernandez et al. And they included roughly 17 trials and just under 2,600 patients with bronchiolitis. And to be really specific about their inclusion criteria, they included infants with bronchiolitis who did not have a history of recurrent wheezing. And so any RCT that made mention of a history of recurrent wheezing as an inclusion criteria would not have been covered in these guidelines. So they only included trials where we either knew that this was a first-time episode of wheezing, or if they couldn't ferret it out and we weren't sure if it was or if it was not, they were included there as well. So they found there were two probably important figures for our discussion. One relates to hospital admission, and the other relates to hospital length of stay, both when corticosteroids are applied in relation to placebo. So to start with, in the emergency department, do steroids impact the frequency of hospital admission? Well, the answer was no, or at least not achieving a statistically significant p-value. So what they found was of the infants that had data on day one admission, so you're in the emergency department, there's a wheezy bronchiolitic in front of you, you give them steroids, do they get admitted today? They found that the risk ratio for admission was 0.92. Meaning that there was an 8% relative reduction in the admission rate. However, the 95% confidence interval crossed 1. So it was from 0.78 to 1.08. And I would tell you that I think that probably was actually adequately powered. There were just about 900 patients in each group. So while sometimes we take umbrage with point estimates that are favorable but wide confidence intervals, in my mind, this is probably not actually the case here. And even if you said, well, I believe that, the absolute risk reduction was relatively small, and so it would have led to a number needed to treat to prevent day one admission of about 22.5. Sorry, Tony, you look like you were going to say something.
Well, I was going to say for our listeners who are driving and don't remember why that crossing the 1 in the confidence interval is important, could you bring that up and then remind them?
Oh, sure, totally. So the best way to say it is that in statistics or in data science, we can never tell you what the truth is. In order to know how much steroids actually reduce the risk of admission in bronchiolitis, right, we would have to know for every child who's ever received a steroid for bronchiolitis, how many of them got admitted. And then for every child in the course of human history who did not, how many of them got admitted. And that would be an exact representation of truth. We can never achieve that in real life because we have to sample small. Instead of taking the whole population, we take what's called a sample, or we take a subgroup of the population. We then use the sample size to calculate how likely it is that we have estimated truth. And so what we mean when we say the 95% confidence interval of an estimate crossed 1 was that we mean that there is greater than a 5% chance that there was no difference in between the two groups. The technical statistical way of saying it is that the probability that the findings were caused by chance alone exceeded 5%, or that there was an alpha value greater than 0.05. That's very mathematically complex to sort of think about as you put it in your head. And so in most cases, this is roughly equivalent to saying, I am less than 95% sure that this thing is true.
Got it.
Which, in practice, at the bedside, I have to tell you, my threshold for clinical action is very rarely 95% certainty. But because we do so many trials, the worry is that if we accept a greater alpha value, that we will over time wind up with a large proportion of spuriously positive trials. So when you're at the bedside, you might say to yourself, in this one patient who's in front of me right now, I'm 90% sure that they have asthma, so I'm going to treat them like they have asthma. That would probably suffice for you. Except that if you are in the case of reading thousands of clinical trials that are published every year, if you accepted a higher probability of chance findings, it would mean that you might wind up with potentially hundreds of false positive trials every year, which is why we use such a strict threshold in the clinical research space.
Okay, that was helpful. So now going back to the Cochrane review, because it crossed one, it made you more skeptical of the data.
Yeah, exactly. So the way that this would be presented is to say, in the Cochrane review, because the confidence intervals cross one, we would say that there is not a statistically significant reduction in the proportion of day one admissions in kids who are given steroids in the emergency department. Or, put in plain English, kids who get steroids in the emergency department are not statistically less likely to be admitted than those who don't. Okay. That was also true on the day 7 admissions. So they took that same group of papers and then they said how many of them followed the kids out for a week. Most of them actually did. So there were about 750 kids in each group. And again, there was a non-statistically significant difference in the proportion of kids who got admitted. So the point estimate was 0.86. But again, the upper limit of the confidence interval there was 1.06. And so we would say there's not a statistically significant difference in admissions among kids who are in the emergency department receiving steroids. And to take that out, because this is a podcast for pediatric hospitalists, well, okay, but they've already been admitted. Once they're admitted, does it matter in terms of length of stay? Can I get them home sooner? That was addressed in Figure 8 of the Fernandez-Cochrane review. And truthfully, this one, I would tell you, is like strikingly negative. So that not only did the confidence intervals cross the center line saying that it wasn't statistically significant, but even if you said the point estimate is perfect, it would only have been about a 4-hour difference in the length of stay for these kids between kids who got steroids and kids who didn't. So I would kind of chalk that data up and say, there's maybe a signal on whether or not kids get admitted from the emergency department, but not enough that I would call it a statistically significant signal, and probably not enough to be a clinically actionable signal. But boy, there's really no signal in whether or not steroids reduce the length of stay for kids. So that's the global aggregation of all the evidence on steroids for them. Now, it's important to note what's missing here. Well, the things that are missing here are, one, caveats to the population. So caveats to the population are, right, this was a population of infants who've never wheezed before. There's a median age across these studies of approximately 3 months. So these are the babies with bronchiolitis. They're not the toddlers with bronchiolitis, which again makes sense because that's who largely got admitted pre-pandemic, as opposed to in our post-pandemic world. And thing two is important to say, all of these children were floor level patients. So because you and I are going to have some nuance in the discussion here about, like, is it right to use these in the ICU? I do want to say that none of these trials occurred in the ICU. And in fact, to the best of my knowledge, there have been no randomized control trials ever on steroid use for critically ill bronchiolitics, which I know is frankly where we use it most, which is kind of why I'm here having this talk with you as opposed to another hospitalist.
Yeah, very fair.
But let's take a quick pause and dive into the actual clinical trials that powered that Cochrane review. So to briefly recap where we are right now, the AAP says don't do this. And I've just told you that there is a Cochrane review that says you probably shouldn't do this. So if I'm going to come up with a reason to do this, I better tell you something strikingly different in the actual clinical trials that power the study. So there are really three, in my mind at least, three randomized control trials worth looking at here that evaluate steroids, steroids specifically in the context of bronchiolitis. Importantly, two of those studies were included in the Cochrane review, and one of them was not. And the specific reason I guess there's really two reasons. One, because it came out about 6 months after the Cochrane review was published. And two, because it specifically looked at infants with a prior history of atopy. So infants who had wheezed before or with a concerning family history for atopy, which would have been excluded from the Cochrane review based on their inclusion criteria anyway.
Okay.
All right. So let's jump in then to the primary evidence that looks at steroids and bronchiolitis. And to sum it up quickly, I'm going to tell you about three randomized controlled trials. One of them is negative, one of them is positive, and the other one's maybe in the middle. So let's start with the negative trial first. So there was a study performed by, I hope I'm pronouncing this correctly. There was a study performed by Cornelli et al. This was in 2007, and it was in the New England Journal of Medicine. So this is the oldest study, and it's also the negative study that we have. So this was a good-sized, well-powered RCT. So they took 500 infants with a first-time history of wheezing. So again, infants, first-time history. And they randomized them to either receiving Decadron or oral dexamethasone, to use the generic name. And they dosed it at 1 milligram per kilogram of body weight. And they gave a single oral dose of dexamethasone to children with bronchiolitis or a dose of placebo. And these were children with bronchiolitis in the emergency department. And their primary outcome was admission 4 hours afterwards. So wheezy bronchiolitic in the ED, you're looking at them, you're suctioning them, you're doing all the things in supportive care. You also give them a dose of Decadron. You come back and see them 4 hours later and you decide, I'm going to admit this one, I'm not going to admit this one. And this was a true double-blind RCT, so the clinicians making that decision were blinded to the treatment allocation here. So just to get right at it, this was a negative study. And I'm so sorry, Tony, I made a typo or a misstatement at the beginning. I told you that this was 500 infants. This was actually 600 infants.
Okay.
So just to go right at it, this was a negative study. And I thought this was a pretty well done and well powered study. They had 600 infants. They randomized to either receive 1 milligram per kilogram of dexamethasone as a single dose or placebo. And they had hospitalization data available for almost all of them. So like less than 2% here were lost to follow-up. This was a really well done trial. And overall, what they found was that hospital admissions occurred almost identically, 39.7% in the Decadron group versus 41% in the placebo group. And the p-value was 0.74. So like not even close to being a statistically significant difference here. Interestingly, they did find that the patients who received steroids had a lower respiratory distress assessment instrument score on the 4-hour assessment, although it was a pretty small difference. It was a difference of a half a point, but it was a statistically significant finding with a p-value of 0.03. They also had, for whatever reason, slightly better improvements in heart rate and temperature, but not in respiratory rate at the 4-hour reassessment. And again, I thought this was a pretty well done study. They also, while their inclusion criteria here were that they were only including infants that had a first-time history of wheezing, they did take into account whether or not there was a family history of atopy. So whether there was any family history of asthma, as well as whether the infant had a personal history of eczema. And they included that as a pre-specified subgroup analysis. And to cut straight to the chase, there was no difference in any group. I mean, this was truly, aside from that one difference in the respiratory distress instrument scoring, this was a strikingly negative study. And I would tell you, if this was the only study that was out there, I would say, yeah, probably steroids don't work, at least in this patient population in the emergency department. And just one thing before we move on to other studies, I think the only caveats I would give to this study, and again, I want to applaud these authors, this was really well done, but the only caveats that I would sort of offer to this study are, thing one, this is, again, a young group of infants. The average age in this study, or the median age in this study, was only 5 months, and the IQR here was only 2 months. And so really, this is only going to include a patient population between 3 and 12 months, and nobody older than that. So if the question is there a difference in response in older wheezy bronchiolitics, like the 1 and 2-year-olds, the answer based on this study is, I have no idea. But other than that, I would tell you this study says, boy, probably infants with bronchiolitis, steroids in the emergency department don't make a difference in terms of being admitted. So any questions about that one? Because I would tell you, I think that one is the best evidence I have against the use of steroids. And then we'll talk about the other 2 trials.
The thing that stood out for me, based on our last conversation for using it in the PICU, kind of changing the venue, is the respiratory distress improvement. Because we discussed last time how you, in the ICU, you're using albuterol and steroids to really prevent more aggressive intervention that has more side effects like intubation. And that would almost be a point in favor of why you all are using it almost in the PICU to help with that respiratory distress. But otherwise, I agree with everything you said.
Yeah. I think for me too, we always run into, my overall assessment of the evidence would be that I think by and large, probably albuterol and steroids don't work for most patients with bronchiolitis. I do think my assessment of the evidence in general is that there's probably a subpopulation for whom they do. And if that prevents an intubation in one of those kids, or if that prevents an ECMO run in one of those kids, then I would tell you, boy, the stakes are much higher there than just being admitted to the hospital for oxygen and suction care.
Yeah. I would agree with you.
That said, to try and minimize my amount of editorializing, let's talk about the other 2 trials. And so in summary, so far, I told you we were going to talk about 3, 1 negative, 1 positive, and 1 somewhere in the middle. We just talked about the negative one. Let's talk about the somewhere in the middle study.
Okay.
And then we'll do the positive one at the end. Because again, the patient population here is different in the positive study. So let's talk about the study in the middle. So again, a really well done study by Dr. Plint et al., also in the New England Journal. Apparently, if you were in the mid-2000s and a bronchiolitis researcher, NEJM was interested in your stuff. I'd love to see that era come back. But anyway, so they did similarly. This was a large-scale, double-blind, placebo-controlled RCT. They had 800 infants. So again, for a pediatric trial, this is really good size. And again, we find ourselves in the pediatric emergency department with kids ages 6 weeks to 12 months. And again, it had to be their first time episode of wheezing. So they excluded anybody with a history of recurrent wheezing. So even if the kid was 12 months old, but this was their second episode of showing up in the ED for bronchiolitis, they were out. But That was the patient population that we had. They randomized those kids in a 2x2 factorial design. So you could either get placebo, and I think if I remember correctly, their inhaled placebo. Yeah, it was nebulized saline, and as well as an oral placebo. So saltwater inhalation plus an oral placebo. You could get inhaled racemic epinephrine and an oral placebo. You could get inhaled saltwater or inhaled placebo plus dexamethasone, which was a single dose of 0.6 milligrams per kilogram. Or you could get racemic epinephrine inhaled and dexamethasone 0.6 milligrams per kilo orally. So again, because these are emergency department doctors, they were interested in a question of hospital admission, and they were interested in the question of hospital admission within 7 days. And then they had secondary outcomes of admission on the day of presentation, as well as a few other like respiratory distress assessment scores and things like that. So what was interesting about this study, and the reason I say it's somewhere in the middle, is if you take a look, I assume a lot of our audience is driving here, but if you take a look at figure 3 of this study, I'm just going to quickly summarize it. So basically what they found was that in the group of children who received inhaled racemic epinephrine plus oral dexamethasone, there was about a 5% reduction in the day 1 admission rate. So if you look at that, say a number needed to treat of 20. So an absolute risk reduction here of about 5% of kids being admitted beginning on the day of presentation. And that reduction was sustained out to day 7. So basically 5% fewer kids got admitted on the day that they presented to the emergency department. And then that 5% of kids did not bounce back and get admitted on days 2, 3, or 4. So essentially the curves are flat between day 1 and day 7. And when they just looked at this in the unadjusted analysis, or in a head-to-head comparison of placebo versus the combination of oral dexamethasone and inhaled racemic epinephrine, what they found was that there was a relative risk for 7-day admission of 0.65, again, an absolute admission reduction of about 5%. And they had a confidence interval of 0.45 to 0.95 and a p-value of 0.02, which would have been statistically significant. However, because this was a 4-way factorial trial design, right? So there were 2 racemic arms, 2 decadron arms, and then you could get any combination of placebo, decadron, or racemic. After they adjusted for multiple comparisons, which I think they did using a Bonferroni, which is actually a strikingly simple thing to do. Basically, you take your p-value of 0.02, you say, I made 3 comparisons, so I have to multiply that by 3, and then they wound up with a p-value after adjustment of 0.07, which technically speaking, you would say is no longer less than our 0.05 number. And so the mathematical phrasing for this was not statistically significant after adjustment for multiple comparisons. That being said, I wish this trial had subsequently been repeated because I do think in my mind, this is one of those findings that I think to myself, gosh, that's actually a pretty promising and clinically meaningful outcome. If you told me that you could reduce the absolute admission rate for infants with bronchiolitis by 5%, I would tell you that would be thousands and thousands and thousands of children annually that we could keep out of the hospital.
Agreed.
And so this, for me, falls into that category of study that makes me think, gosh, I don't know who it is, but it does seem like there's at least a subpopulation here of infants who might respond to the combination of inhaled bronchodilators, which to the extent you would argue that racemic is an inhaled bronchodilator, I think I would. Bronchodilator versus tracheodilator, they're pretty much the same mechanism as inhaled albuterol, and corticosteroids. The one thing I wish we could do is repeat this trial and repeat it with a larger sample size and also repeat it with an older age population. Because as we talked about, this is really only again, their inclusion criteria were only looking at infants under 12 months. And very similar to the Cornell study, they had a median age of only 5 months in the trial with an interquartile range of 3 to 7 months. So it really doesn't tell us anything about those 12 to 24-month-olds with bronchiolitis who show up in the emergency department. Might they respond better? Maybe. Might they respond worse? Also maybe. Based on the evidence I have, I couldn't tell you.
Yeah, it's interesting because up until this past couple of years, post-pandemic, the numbers, as you already said, the numbers have gone up in the above 12-month-olds who are getting admitted. I don't know, nobody does, if we're ever going to see a repeat of this past year again. I hope not, genuinely, for many reasons. But I also think that there is something to this yearly kind of almost vaccination of sorts, where everybody gets RSV, and us interrupting it for 2 years had consequences we did not intend or foresee that we dealt with. And so I don't know, but you bring up a great point, this 12 to 24-month-old. And even in the guidelines, they talk about that paper, and the tone of the discussion there is, it's a really interesting study, came back relatively positive, but had this statistical issue, and there's not much else on it. More evidence has to be done, but they really end up kind of saying maybe for racemic epi, but probably not, is their tone. They say do not administer epinephrine to infants and children diagnosed with bronchiolitis, give it a grade B. But the way they end that discussion is, further data may help to define this question. And it almost like maybe, based on that study, maybe.
And it's frustrating, it speaks to how difficult it is to organize and fund large-scale multi-center pediatric trials, right? Because this paper came out in 2009, right? If this had been an adult study, we would have seen cute acronyms for this study, and then we would have seen versions 1, 2, 3, and 4 all rapidly published within the next 5 years.
Yeah. Yeah, you're right.
I think about this with the oxygen therapy trials that have come out in the adult critical care world. I also think about this with targeted temperature management. We have marginally positive studies on the adult side, and they are able to rapidly get repeated, enroll thousands of patients, and we have definitive answers within 36 months. And that's just really difficult to do in the pediatric world. It's been 13 years since this study was published.
Yeah, we haven't anything that's good again. Yeah, you're right. It's a real issue, especially with something so common. I mean, there are some very rare issues that we deal with in pediatrics. This is not one of those. This is extremely common.
Yeah. All right. So we've covered 2 out of the 3 clinical trials. We've covered the no. We've covered the maybe. And now I want to cover the yes. So the last study I want to talk to you about, I should caveat by saying this study was not included in the evidence summary of the AAP policy statement, and also not included in the Cochrane review of management of children with bronchiolitis, where they covered bronchodilators and corticosteroids. And there are, again, the reasons for that are, 1, that it came out after the Cochrane review, and 2, that the enrollment criteria here was slightly different than the prior studies. So let's talk about it. So the last study I want to talk about is done by Dr. Al-Ansari et al. And again, I hope I'm pronouncing that correctly. So the last study I want to talk about had slightly different enrollment criteria from the other 2. So this was a study done by Dr. Al-Ansari et al. And published in Pediatrics in October of 2013. Also a randomized double-blind controlled trial looking at oral dexamethasone for bronchiolitis in infants admitted to a short stay unit with bronchiolitis. So this study was interesting to me because the key difference here was that they only enrolled children in whom they thought there was a biologic plausibility for response. So they looked at infants who had acute bronchiolitis who they thought had likely an asthma risk. And they defined that by saying either there was a family history of asthma or the infant had a personal history of eczema. And to be clear, they did define personal history of eczema either based on the historical notation of that from the parents, or if the kids showed up with a rash that they said, yeah, that's eczema, they would have been eligible for inclusion in the study. And the other reason this study is different is that they included infants out to 18 months instead of out to 12 months. So now that we've harped a little bit on the differences in the inclusion criteria, what did they find? So they randomized 200 kids, and they administered 1 milligram per kilogram of oral dexamethasone on the first day, and then 0.6 milligrams per kilogram for 4 more days. So a total duration of therapy here of 5 days. And they randomized 200 children to either dexamethasone or placebo. And what they found was that their primary outcome was the time to readiness for discharge from the short stay unit, which is often done as a proxy for hospital length of stay, because we all know there are things outside of patient condition that influence that, such as if a patient's ready to go home at 6 p.m., but the team is rounded the day before, they might not get discharged till the following morning. So readiness for discharge is designed to get around those system-based factors. And they had standardized criteria that they used for how long you had to be off oxygen and feeding well to be considered, quote, ready for discharge. But either way, what they found was that the geometric mean readiness to discharge time was 18 and a half hours in the dexamethasone group, compared to 27 hours in the placebo group. And this, when they did that out, they found that was a relative reduction of 31%, leading to a p-value of 0.015. So a statistically significant reduction. And, I would tell you, you could kind of quibble here about but does a 9-hour length of stay really matter? But I would tell you that, gosh, if these are kids in a short stay unit, right, they're sort of by definition, not all that sick bronchiolitics, right? Even in the placebo group, the average length of stay was only 27 hours. So while 9 hours doesn't seem like a lot, when you put it on that time scale, a 30% reduction in length of stay, I also think is clinically important. The other thing that I think clinically, sorry, go ahead.
I was going to say, looking back at what we went through this past year, when the hospital was overfull, we had kids overflowing in the ED, a 9-hour reduction would have gotten more kids in more beds a little bit faster. Clinically, hospital-wide, it would have made a difference. I mean, that 9 hours, I think, is more relevant than someone listening who doesn't have experience doing this would realize. That I would say that's important.
Yeah. And I think for me, as an intensivist, one of the other things I think about here is, does it get kids better quicker? And even if it doesn't get kids better quicker, does it prevent deteriorations? Yep. So one of the other things that I think was interesting in this study for me as an intensivist was that they also had a statistically significant reduction in intensive care unit admissions. So again, remember, a relatively small study. There's only 200 kids in the study, which means that there's only approximately 100 in each group. It wasn't a perfect split. It was 102 and 98, but about 100 kids in each group. But what they found was that 5 children in their control group, so 5 out of 98 children, or roughly 5%, in their control group wound up having to go to the ICU. And none of their children, so 0 out of 102 of their children in the dexamethasone group, wound up having to be admitted to the intensive care unit. So the reason that I think this is an interesting study are that there are really 2 reasons. 1, it did cut length of stay, and so it's a positive study. And 2, it cut intensive care unit admissions. And one of the things that was interesting for me about bronchiolitis this past year was not only were we struggling with hospital beds, we were also really struggling with ventilator availability, high flow circuit availability, non-invasive ventilator availability. And gosh, I think more than anything else, the thing I was struggling with was a lack of availability of respiratory therapists. Yeah. So there's also a really big difference in terms of hospital systems in in terms of the intensity of care between a child who is on the ward needing supplemental oxygen, but able to be cared for and have his routine suctioning performed by a bedside nurse, and at that same child who gets hooked up to a high flow or non-invasive circuit, and all of a sudden they need a very different care team. Even if you work in one of the wonderful hospital settings where high flow is doable on the floor, and there are some of those out there in the United States, even if you work in that situation, it's still a much higher burden on your respiratory therapy staff to have a much greater proportion of kids on high flow circuits than it would be if you had that same population, but on low flow oxygen.
Yeah. And I mean, nationally, respiratory therapists are there's a short supply of them everywhere in the United States right now. So it's not a bad thing. What you're saying, I agree with 100%. So that we've now had one study where they did not work, one kind of in the middle, and now one where it seems to be working.
Yeah.
And in this one, they had older kids, and there's an atopic history, which is a very different group.
Yes. I do think the differences in inclusion criteria are important. It is also worth noting that these findings, when you kind of summarize these three trials together, there are some areas that just make me wonder, that make me feel like the jury's still out. And the reason for that is simple. So reason one is that even though the positive Alan-Seri study was specifically targeting infants with an atopic history, the other two randomized control trials that were done earlier, both the Plint study and the Cornelli study, while they weren't looking for that patient population, in their table one, like demographics tables, you can actually see that somewhere between half and 70% of their infants did have a positive atopic history, which give me a little pause and say, like, gosh, if that's really true, why was the Cornelli study so strikingly negative? Like, I can get on board with saying, hey, the Plint study where they saw an effect was the combination of steroids and racemic, and 60 to 70% of their kids had an atopic history. Maybe it just worked better in that group of kids, and the subgroup analysis was too small for them to be able to parse that out. Okay, I could buy that logic. It does bother me a little that the Cornelli study had such a high proportion of kids with an atopic history, and that study was so strikingly negative. And so aside from the fact that the Cornelli study was like a single dose of dexamethasone, as opposed to a 5-day course in the Alan-Seri study, I can't come up with another great reason for why the results would be so different.
I was going to say the age difference. Do you think that would be?
I would that too, Tony, but even though their inclusion criteria for the ages were different, if you actually look at the median age across the studies, it really wasn't that different. So the positive Alan-Seri study, they deliberately included infants out to 18 months, but they still wound up with a median age of only 4 months compared to the median age in the Cornelli study of only 5 months.
Okay.
And so when I sum this evidence together, I think in my mind, I still can't get over the sinking feeling of, gosh, this works sometimes, or this works for a subpopulation, and our trials, at least as of yet, haven't figured out who that subpopulation is. And I think that's why we're seeing such variable results across the clinical trials. The closest we've gotten to getting to yes, right, is the Alan-Seri trial where they said, all right, we're just going to take everybody with an atopic history and see if that's close to it. And again, it was a positive trial. I'm still not quite convinced we've hit the bullseye. Like, I still think we could probably try and better refine the patient population in whom this works and in whom it doesn't. But I would tell you that in clinical practice, the way I put these studies together is I usually personally do not start steroids empirically. I wait and see if a patient is bronchodilator responsive. And if the patient in front of me is bronchodilator responsive, I think I've convinced myself that they look enough like the Alan-Seri study that they would be a patient in whom I would be interested in using corticosteroids.
Interesting. It's making me wonder. I don't know if you remember the guidelines before the 2014 guidelines, where it was basically try albuterol or racemic epi. If they work, keep using them. If they don't work, stop using them. And if you were to ask me to speculate, looking at my crystal ball, now this is all speculation, what I'm about to say, and what will the AAP guidelines look like next, based on what we're seeing with another really good study coming out, I would say it's going to go back to that, where you would try and see if it works. It's, if anything for me, it's clouded the picture more than it's cleared the picture.
Yeah. I think that's my read of the data too. I want to be clear and upfront that I, think that the now outdated but still most recent AAP guidelines that we have were thoughtfully done. And I think that they worked hard to use the best level of evidence available to say this is what we should do in general. My argument is more that I think there's probably space for nuance, both in the population we see and in the guidelines. I worry that there is not a single phenotype of bronchiolitis in patients that we see. In my mind, a 2-month-old who comes in with, respiratory failure on day 1 of RSV, they sound completely crackly, and they get intubated in 5 minutes because they're apneic in the emergency department. Deep down, I believe that is a different phenotype than an 18-month-old who's been admitted 3 other times for wheezing with viral illnesses, who is now being admitted for their 4th round of human metapneumovirus or RSV, and they sound much more like an asthmatic. Now, to be clear, the second patient isn't covered at all in the guidelines that we have, right? We're deliberately excluded from the guidelines, but we still are going to put the ICD code of bronchiolitis on that second kid. And in my mind, I'm not totally convinced that those 2 kids have the same disease. Or if they have the same disease, that the clinical phenotype of that disease is the same between them. I can't help but wonder if their response to therapeutics is likely to be different.
Yeah, I'm going to agree with what you said. I think Dr. Ralston and her colleagues, she was the first author on the guidelines that we still have, the 2014, really did as thorough and as conscientious a job as they could with the evidence they had at the time. But I think looking at it now, what we have in front of us is a set of guidelines that are expired, that remove children in the critical care setting, they're not involved, and then remove children with recurrent wheezing, which in the year we had really was a bulk of the kids that we saw. I can't, looking back, and again, this is subjective now, I don't have the data in front of me, but I remember seeing a lot of children who had wheezed or had bronchiolitis before, and some I remember had the same virus 2 times in a row, a few months apart, and came back with the same condition. So it's a challenging thing, and I think you're right. It's not a cookie cutter thing, bronchiolitis. I think it is going to depend on the virus causing it and the host response to that virus to tell us what direction to go. We just don't have that information as of yet. Maybe one day when you and I are retired, that information will be readily available.
And I think the other caveat I would put in here, right, is that every RCT we have takes otherwise well infants. And I would say about 30% of the patient population I see in the ICU would not qualify as an otherwise well infant anyway, right? They're either an ex-premature infant who wouldn't qualify for any of these guideline statements, or they have some other, chronic medical comorbidity that might influence their care in other ways. And I think and hope as we continue in the bronchiolitis research space that we need to be more thoughtful about deliberately including those patients or studying them separately. to not just say, look, we're gonna limit our clinical trials to first time wheezers. We're gonna limit our clinical trials to babies born at term who have no other medical conditions. That's helpful, but it only maybe helps me for somewhere between half and 3/4 of the patients I treat, right? I still am stuck with like, yeah, but what do I do with this 12-month-old X 28-weeker who's actually on a 1/4 liter oxygen at home, and coming in with RSV, in whom I think you have real biologic response to therapeutics is going to be different.
Yeah, John, I don't have an answer for that. That's a great question. I agree. I agree, because we get those kids after you all discharge them from the ICU. They come to us on the floor. And I would love to see them included in more of these, or at least include children with recurrent wheezing, of which there are numerous. Yeah. I mean, if we can narrow it down and say, okay, the kids with significant congenital heart disease and cystic fibrosis, we'll exclude them. And then like bronchopulmonary dysplasia, fine, we'll exclude them. But let's get everybody else in there. It would be nice. And then some more older kids, because we're seeing that now. It's a great discussion. And again, I think it points to what I love about medicine is that, we came at this initially from very different places, thinking, what is the other side doing? And I'm sure we're not the only ones. Across the country, this has been happening, where intensivists and hospitals are saying, what is the other side doing? And here we have this nice conversation, discuss the data, and realize that really there's just the data is helpful. At the time, it was the best we had, and it was done very thoughtfully. But right now, there's more questions than answers. And I think what we said earlier is we'd love for the AAP to put a little bit of time and effort behind this when able, to get another very good group together and answer these questions, because it will help us, because my suspicion is the guidelines will change again and get a little bit softer in terms of what you can or cannot use, and maybe include the PICU, include the intensive care unit in them. Wouldn't that be wonderful?
That would be fantastic. And I would also say, I think there's really a need here for, a multi-center research group that's dedicated to respiratory failure. I know that there are some groups out there who are working on them, but it continues to blow my mind that a condition that represents almost 20% of pediatric hospitalizations, the best level of evidence we have is from RCTs that are more than 10 years old.
Yeah, that's a very fair point. I mean, to be honest, the past couple years has thrown a monkey wrench, because we had a wonderful trial going here headed by Dr. Allison Williams for non-RSV bronchiolitis, and there almost wasn't any. We had to stop doing it. So this past couple years has made that challenging.
Yeah, no, that's a fair point, and I am hopeful that the season that we just lived through will sort of help us decide whether or not this is a research priority worth pursuing. I think it was a real open question during the height of COVID, is there going to be another RSV season? Is there going to be another RSV season before there's an RSV vaccine, which seems like it's, in the pipeline for the next 5 to 10 years? And the answer to that seems to be a definitive yes. And we should start thinking about how we can make ourselves more efficient in the intervening time.
Well, I couldn't agree more, John. This was great. Is there anything we should have talked about that we didn't talk about?
Gosh, I think the only caveat I want to say is, in the AAP policy statement on the use of corticosteroids for bronchiolitis, they also sort of reference the possibility of harm with the administration of corticosteroids, with the rationale of prolonging viral shedding. And the citation used for that, in my opinion, just does not have the strength to back that statement. The only thing I want to say about it was that the citation used by the AAP to make that argument was a 1986, also New England Journal paper, but authored by by Dr. Hall et al. It looked at 22 children who were receiving quote unquote suppressive doses of steroid therapy. So those were children receiving high dose, long-term corticosteroid therapy with a minimum duration of 2 months, and some kids who had been on steroids for 3 years prior to infection with RSV, for which they were hospitalized. And they did indeed find that the children who had been receiving corticosteroids for months prior to admission had a longer duration of viral shedding, 9 days compared to 4 days in the kids who weren't receiving corticosteroids. But, they also found that the kids who were receiving high-dose steroid therapy had a lower incidence of ICU admission and death than the kids who weren't. So I would argue that I think that I just don't think a 5-day steroid burst is in any way comparable to months of corticosteroid therapy for immunosuppression for either rheumatologic or oncologic conditions. And so I would argue that I think the worry about immune suppression and prolonged viral shedding in RSV from steroid therapy, while a real theoretical consideration, we just don't have the data to back that actually occurs in real life.
Yeah, I would agree. Months is much more than a week, than 5 days. I honestly couldn't agree more with that. And I would agree with your assessment of that. Now, John, as a friend of the podcast, what this means is when we are in need of ICU experience, we're going to call you. Just so you know that title comes with that responsibility.
Well, gosh, I'm always happy to talk to you anytime. With the caveat being that I don't think there's an intensivist in the country who could speak with the voice of all of us. So my opinion is just that.
That was said tongue-in-cheek. For those of you listening, that was tongue-in-cheek. It's a very fair point. John, thank you so much for your time. I appreciate it a lot.
Thanks, Tony. Have a great day.
Time for our acknowledgments. I want to thank our special guest again. I really do appreciate your time. I want to, as always, thank the UPMC Children's Hospital of Pittsburgh, and specifically the Paul C. Gaffney Division of Pediatric Hospital Medicine for continuing to support the podcast. I want to take the time to remind our listeners that there is CME associated with most of our podcast episodes, courtesy of the University of Pittsburgh. So thank you, University of Pittsburgh. Please just click on the link at the bottom of the podcast, takes you to a web page, create a free username and password, answer some questions that I write that are not hard, and that's it. You get AMA Category 1 CME credit. I want to, as always, thank and acknowledge Dr. Megan Keene Tarchichi, who helps me with everything. But I really want to thank you all who are listening. Thank you for letting me come into your earbuds or your car, wherever it is you are. I really appreciate the fact that you do that. If there's anything you want to hear or think we can cover better, any comments, suggestions, compliments, whatever you want to do, again, as always, please feel free to email me at tony.tarchichi, tarchichi, @chp.edu. Thank you again, everybody. I hope you have a great day. We'll see you next time.
Thank you for listening.